Hi, thank you. Good to see
Thank
you.
you.
How are you?
Fine, fine, fine. So we are meeting after June when we met in Keto.
Yes, yes,
So
yes.
happy
It's been a while.
and thankful to have you on the Metabolic Health Conference, India's low-carb conference platform. And this is the third one, of course. We had a couple of them last 2 years, and so happy to have you in the session. So I'll just briefly start with introduction. So for the viewers, of course, I'm Shashi, a metabolic health coach from D Life, India's first and only award-winning low-carb platform. The platform was founded by Anup Singh back in 2014, who is an IIT Roorkee silver medalist and with Icons of India awardee. He also pioneered the low carb movement in India. Anup's groundbreaking 100 grams per day protocol, 100 grams per day carbs protocol, which he developed in 2012, made LCHF and type 2 diabetes management very easy for Indians and especially vegetarians. In 2020, he also launched the D-Life Diploma course, the only NSCD approved, Government of India approved program with the largest 144 CPD hours. So Anup Singh and I, of course, we both co-organized India's historic Metabolic Health Conference, the one and two. So I take the pleasure in inviting Dr. Adrian Mota. So he is a physician and a researcher known for his metabolic health, ketogenic therapy, and energy metabolism. With a very strong background in clinical research, he has explored the impact of ketones on human physiology, particularly in metabolic and neurological disorders. His work challenges the conventional dietary guidelines, emphasizing the therapeutic potential of low carb and ketogenic diet for improving health outcome. So Dr. Adrian's evidence-based approach continues to shape the conversation of metabolic health, offering new insights into the nutrition, longevity, disease prevention, and especially the lipid, where he is actively involved in the recent publication on LMHR, along with Dave Feldman. So thank you and welcome, Dr. Adrian.
Thank you. Thank you. I'm very thankful for the invitation, for the opportunity to reach out to everybody in India. And the pleasure is mine, really. Thank you.
Thank you. So we'll start the first question, Doc. You have studied the ketone metabolism very, very extensively. How does ketosis fundamentally change our body's response to lipids compared to the carb-based metabolism?
You could say that the same physiological thing that induces ketosis at the same time changes our body's preference, so to speak, for burning fat. An analogy I usually place or usually use with my patients is that imagine your body is a house in a very cold mountain, and imagine you have a gas stove, and you have wood logs to produce heat, and you need heat to, boil water or to cook or to something like that. Well, chopping off logs is hard. It requires effort. And turning on the gas stove, it's just easy, instantaneous. So if you have available gas in your stove, you won't mind about, you will forget almost you have logs. You just won't use them. Why would you? But if you don't have gas, you have no other option but to go for the logs. So in this analogy, carbohydrates are the easy to access, immediate response fuel, and our fat is the large storage of logs. So when we are not consuming carbohydrates, our physiology has no other option but to go to the fat reserve, and that same process of going to the fat reserve is what starts ketosis. So you could say that when you see ketosis, you are already seeing a very strong sign that our body is relying more on fats in general.
Something which is available in abundant quantity.
Yes, yes, absolutely.
In
Which,
some way,
which, so just to add a very brief idea there, because I think that this is frequently overlooked for other diet interventions. This is the only diet intervention that has a biomarker. If 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 I come to you and I tell you I am following a Mediterranean diet and you ask me for proof, I cannot give you proof. If I say to you I am following The other day I saw a joke like I am following a seafood diet. I see food and I eat it. Well, if I have no way of showing you my diet. The only diet we have a biomarker to track adherence is a ketogenic diet.
Very interesting. We never heard about this before. I think you may have told this in various conversations or podcasts. You may have tweeted it, but somehow I think we have missed it. So this is the only diet which can be tracked with a biomarker. Very, very interesting. So in some people, we see a rise in LDL and total cholesterol when they are on ketogenic diet. Is it atherogenic? Is it bad? How is it? How do you view it?
Something I frequently repeat is that context matters, and that not all LDL elevations are made equal. And at the same time, because context matters, it's not the same to have high LDL on someone following a ketogenic diet after recovering from a heart attack than my very good friend Nick Norwitz, who has never had a heart attack. He's super young, he's super knowledgeable about health, had access to lots of studies, has his genome sequenced, has had more than one, coronary scan. So, I mean, if those two contexts are very different, so we shouldn't treat them equally. And actually, we know there's published literature demonstrating that at the same LDL level, people can have very different risks. So to go back to your question, sure, some people, not all, and I would say not most, because most people start a low-carb diet not being insulin sensitive, insulin resistant, sorry, let me phrase it the other way around. Most people start a ketogenic diet for reasons related with insulin resistance. Therefore, they are not insulin sensible. Those who start a ketogenic diet lean with high insulin sensitivity see these LDL spikes and these LDL elevations. The other people who start a ketogenic diet, not the majority of them, they would see either a very small, not clinically relevant LDL elevation, or even a drop in LDL concentration because their insulin resistance is improving. For those who do see an elevation, then we need to contextualize. Okay, is this elevation likely harmful for you or not? Because what we know is that not all LDL particles have the same atherogenic potential. Some atherogenic particles are way more prone to put cholesterol into our arterial walls than others. And to put an example, this is not the only difference, but just to mention one specific example, LDL particles that are tiny and highly oxidized are much more atherogenic than large LDL particles. And what we've observed in these insulin sensible people who have these elevations is that the type of particle they have the most is this large, not harmful LDL particle, or not so harmful LDL particle. And at the same time, if they don't have insulin resistance and they don't have inflammation, their arterial wall is better protected. And let me be clear. This still needs research. I mean, I wouldn't want to convey the idea that insulin sensible people are not at all at an increased risk. The data we have so far shows they don't have an increased risk due to the LDL or to the high ApoB. This doesn't mean they are protected or immune to plaque progression. This simply means that they are definitely a different risk profile than the high LDL elevations we see for other reasons. So I know I'm not giving a straightforward answer, but I think that the correct answer is not everybody will see it. It's a minority of people on a low-carb diet. And in those cases, you need to identify the context in which LDL went up. Let me tell you something. In my practice, in the patients I serve, I have only seen an LMHR once, mostly because LMHRs are healthy people, so they don't need to go to the doctor. All the other people have counseled on a low carbohydrate diet, they tend to see what I described before, either no change in LDL or even a decrease in an LDL reduction.
So in many of the cases, we see that there's a drop in triglyceride, increase in HDL, and there would be a slight bump up of LDL. Typically in India, the average LDL which we see is 120, 130 milligram per deciliter, and the total cholesterol will be around 200 to 220, with some exceeding and some at low. So how do you see this? Would you see that the drop in TG, increase in HDL, this this particular drop and increase plus the ratio and the slight increase in LDL, how do you
I
decide?
think that those are the markers of better metabolic health. And we shouldn't, I mean, our brain likes, straightforward, simple answers. And this is the one reason that explains it all. But I like so much better what you outlined right now, which is a pattern, not a single change. We see a pattern of a slight bump in LDL, triglyceride reductions, slight bump in HDL, and this triad, so to speak, um, signals that something different is happening in your physiology. I think perhaps it's important or useful to remember why we care about LDL at all. And we care about LDL because it's a cardiovascular risk factor. However, it's not the only thing we consider for evaluating cardiovascular risks. And in the studies, actually, some of them are published already. When we analyze with the 10-year cardiovascular risk calculators, those patients, even those who had a slight bump in LDL, as you described, because the other things in their health improved so much, their cardiovascular risk was reduced despite, or you could say even with that LDL pump. So we know that we are reducing cardiovascular risk because we are improving blood pressure, we are improving insulin sensitivity, we are improving many other aspects that contribute, inflammation, for example, that contribute to cardiovascular risk. And sure, I mean, even if that small LDL bump was physiologically relevant in the big picture, it's being compensated for the other health improvements.
How would you have, can you give some clarity on this LDLP, oxidized LDL? I think though it is not very much measured in India. Let me tell you the situation in India now. In India, we primarily see the LDL and total cholesterol. Even ApoB is not seen as much because whenever as health coaches, when clients comes to us and when we see the lab report, we don't see ApoB measured, we don't see the other, neither LDLP nor oxidized. Primarily, it is just what is seen is total cholesterol LDL. That's all, finish, and then statin. So what is your view on this oxidized LDL, LDLP?
You're touching on a very important point, and I mean, do correct me if I go too technical on some things. It's very important to emphasize that the LDL we most frequently see in clinical practice is the total concentration in blood. And part of the reason why you can see different risk profiles with the same LDL level is that you can have 130 milligrams of deciliter of LDL distributed in a lot of small, dense particles or in a few large particles, large and fat particles. They would give you the same concentration. And as we already discussed, they have different potential for atherogenesis. That's one part of the story. However, most of the LDL we see in today's world and clinical practice is calculated, not measured. And it's calculated with, there are many formulas. The first one and the one that's most used still today is Friedewald's formula. And Friedewald's formula uses total cholesterol, it infers LDL concentration, taking into account triglycerides. And this is very important because if the higher triglycerides go, the larger the error for the LDL calculation becomes. Actually, my lab and I are currently working on a better way to calculate LDL because exactly as you mentioned, here in my home country, we also don't see many fancy lipid metrics. I mean, what we have to work with is total cholesterol, LDL, HDL, triglycerides, and we know that, in other words, the LDL value we are seeing is messy, is error prone. If triglycerides are above 500, the machine won't even calculate it. But we've seen in our data that if triglycerides are above 200, the LDL value, it's already very biased. So we shouldn't focus so much on it. Now, because the LDL concentration is a proxy or a common way to try to infer how many particles there are, it gained lots of popularity decades ago. It's our cheap way of estimating how many atherogenic particles there are. And because of this reason, it was developed ApoB. ApoB is a protein that all atherogenic particles have in common, which is why it's so important, because we know that not only LDL particles are atherogenic. For example, remnant cholesterol particles are also atherogenic. There's evidence suggesting they are even more atherogenic, but they are just very hard to measure because it's very expensive. You need nuclear magnetic resonance of your blood to tell them apart. So ApoB kind of summarizes all the particles with atherogenic potential. And when you see LDL just like that, people are usually referring to the concentration. Sometimes they capitalize it with LDLC. When you see LDLP, as you mentioned in your question, this means LDL, the number of particles, not only the concentration of LDL, the number of particles. And sometimes perhaps you could see SD LDLP, and the SD means small, dense LDL particle. And this small dense is important because as we already touched minutes ago, if the particle is small and dense, it has much more atherogenic potential than your regular LDL particle. Now, if it's oxidized or not, this requires a very different assay to be measured. And oxidized particles are also more inflammatory and atherogenic. So, however, they are not measured in the same way. You also need more advanced and expensive lipids. And to give perhaps a more practical response, I think, and I know not everybody would agree with me, but in a population with so much insulin resistance like in the world today, I think that first of all, we should do as you did. We should look at the pattern. We should look at this change, this change, this changed, not only a single change. We should look at the pattern. But if we were to choose a single thing to focus on, it's likely that your triglyceride to HDL has more physiologic information than your LDL account. Because the most common reason in today's world, the most common reason of high LDL is insulin resistance. That's for sure. There are other reasons, familial hypercholesterolemia, different phases of the inflammation cascade. There are other reasons for high LDL, being an LMHR. But the most common one is by far insulin resistance. When you see high LDL in somebody, it typically means they are insulin resistant. It's part of the other things that will tell you they are insulin resistant. So for me, the most useful marker in a lipid panel to identify is this insulin resistance or not is seeing the behavior of triglycerides and cholesterol and HDL, but also because I know that the higher triglycerides go, the less I can trust the LDL value. I hope that's a better
Yeah.
answer.
Now, in some, we might even see an increased ApoB. Even
Yes, of
though
course.
the markers are normalized, ApoB might be higher. Not in all. We have seen in very few. So is it atherogenic? Is it harmful? Because of late, not in India, but in the international, in the Western world, especially USA, ApoB is given a lot of importance. Now they have virtually abandoned LDL. There they talk of only ApoB. So
Yes.
what do we I want you to explain ApoB in two contexts. One is in the context of ketogenic diet, and one is someone on, let us say, high carb diet and still ApoB is high. How would you view this?
If because ApoB, as I mentioned, is this protein that all particles with atherogenic potential have in common, ApoB has received so much attention. Some people see it as our best way of measuring someone's atherogenic risk. But again, even if I know the exact value of all the atherogenic particles, I am assuming that all of them have the same atherogenic potential. If I just focus on the number of particles, I am basically assuming they all have the same relevance. But we know they don't. That's we know that remnants are more atherogenic. That if I can have the same ApoB number, but if it's in small dense particles, they will be more atherogenic than the same ApoB number with large buoyant particles. What the high ApoB we see in people eating lots of carbs typically signals that they have lots of highly atherogenic particles. The high ApoB we see in people restricting carbs typically signals they have more of the non-harmful or non-so atherogenic lipid particles. Now, some people perhaps would say, why would you stay with your high ApoB number if we have tools to bring it down? You know, like why bother at all? If I know how I can reduce that number, perhaps I don't care if the number if nature is of highly atherogenic or not so highly atherogenic. We can reduce it, and sure, maybe they are right. However, not everybody tolerates medication or has access to medication to reduce lipids, and there are other ways in which we can reduce ApoB. For those patients whose condition allows it, introducing small amounts of carbohydrates in different intervals would bring ApoB down. And we've observed this, my good friend has made a perhaps too extreme case of showing you can do this with awful carbohydrates like Oreo cookies. So if in some clinical contexts, I might not care much about the relevance of high ApoB, but in those other clinical contexts, there are non-pharmacological ways to reduce ApoB. And in some other contexts, perhaps the best idea is, yes, take a medication. So again, I guess that I'm just trying to preserve my job or convince people my job is useful, but you do need, a clinician who sees and analyzes each context to identify what's the best available option in this case. What we can definitely say is that not all high ApoB concentrations are equally harmful, and not all of them require medication to reduce.
I think this is context based, is what you say.
Absolutely, absolutely.
context-based and individual clinician and patient.
Absolutely. You froze a little bit. Can you still hear me? What happened here? I can see you again. Can you hear me? I
Yeah,
think
yeah.
my
There was
connection.
a connection issue. So what
Yeah,
I was
excellent.
asking was, what are the other benefits or other markers we can see which will say that a ketogenic diet is beneficial other than the lipid, if you keep aside lipid markers?
I mean, the if you compare, for example, what matters the most for cardiovascular risk, by far, insulin resistance is the largest contributor. So, and there are different ways to measure insulin resistance. So, for example, and none of them is perfect, but in collection, there are good markers. Seeing reductions in HOMA AR. HOMA is this value you calculate with your fasting insulin and your fasting glucose. But of course, looking at your HbA1c is also helpful. HbA1c reductions are also helpful. Triglyceride reductions would be another signal. Many people arrive with at least mild fatty liver disease. So it's not rare to see reduction in liver enzymes, in ALT and AST. Also, the most common cause for high uric acid is insulin resistance. I mean, gout exists, but uric acid is also one of the things that can signal that there's insulin resistance. So you could also observe reductions in uric acid. You could also observe reductions in C-reactive protein, which is another thing that goes up when insulin resistance goes up. And of course, it signals inflammation on its own. And I mean, frequently overlooked biomarker is the scale. I mean, you would see weight go down. It's you don't need to draw someone's blood to see that. You would see fat reductions, and you can see that with a scale and a metric and a measuring tape, and so all those things matter. However, I think that what I emphasize the most with my patients is how do you feel, because very frequently is not, yes, it's something you can get in a lab, it's something you can, but if my patients go and get a blood sample every month or every 3 months, that's a picture. But how do you feel? That's a video. So many of them report, well, I am feeling less stiff or less pain in the mornings if they have, for example, inflammatory, if they have arthritis, or some other patients say, I feel more energized. Some patients say, I feel, let me put an example there. Years ago, not too many years ago, a group of researchers in the UK at Oxford were, for other reasons, they were using a medication for weight loss. They had lots of MRI scans, and they were mostly interested in the fat around the heart, in the pericardium. But because they had this data, they also were able to look at the tongue. And one of the fat deposits they noticed changed the earliest was fat around the base of the tongue. And this is crucial. I mean, perhaps when I sometimes people want to see, less fat around their bellies or less fat around their hips or less fat. But if you could choose where to lose fat from, if your hips or your tongue, lose it in your tongue all the time. Because what this meant was that now their airway was wider. And this coincided when people noticed they stopped snoring and they were basically oxygenating better during the night when they were asleep. And of course, if you sleep better and with better oxygen, your heart had to pump to work less hard to give oxygen to all your body. And if you had a good night of sleep, you feel more energized and a good. So, okay, this is something you just wouldn't get with. I won't send my patients to a daily MRI scan to see how the fat in their tongue is going, but I can get that same picture if I simply ask them, "How are you feeling?"
I think that's a very important point because a lot of people with metabolic syndrome do have sleep apnea, which is of course very strongly related with all cardiovascular disease. In fact, some doctors will say that you got heart attack only because of sleep apnea. It is said to be so powerful and a big marker. And of course, for India, another big marker is losing belly fat because primarily we are all lean guys. We are very lean people. We appear lean. BMIs are normal, but then we have central obesity, and
Sure.
that's the indicator of
Absolutely.
fatty liver. And I
Absolutely.
think that is one of the
Absolutely.
marker we set it right, and losing that in India, I will say that more than weight loss, it is that inch loss which is much more important in terms of recovering metabolic health.
Much more. Much more.
Look, can you briefly tell us what exactly is LMHR, lean mass hyper responder? Can you also
Sure.
briefly touch upon that study which was published in Lancet, the keto LMHR study?
Um, LMHR is an acronym for, as what you already mentioned, lean mass hyperresponder. And this is a concept and a term that was coined by Dave Feldman in 2017. And what Dave was basically trying to summarize is that those people who see the largest LDL elevations when they restrict carbohydrates tend to be lean, and they tend to have a high percentage of muscle mass and because they hyper respond to the LDL elevation, that's where the name came from. It's not too explicative, but that's the name that sticked. For example, for a while, people have said that we should call it lean mass hyperabsorbers because some people say that what explains the phenotype is more fat absorption. I don't think that explains it entirely. I think that that's perhaps a contributing cause to the phenotype, but I don't think it's the entire phenotype. At the same time, he was developed this concept. Dave very, cleverly identified in the literature that there was already evidence suggesting that it was likely that when insulin sensitive people restrict carbohydrates, their lipoprotein lipase worked harder, worked more efficiently, worked more intensely, and that this would explain both why LDL goes up, why HDL goes up, why triglycerides go down, but also would explain why when you bring a small amount of carbohydrates, everything goes back to baseline very, very quickly. And this is what was coined as the lipid energy model. And the first LMHR paper, which had the observational data he collected from his Facebook group, was published in 2022. And the main physiological paper on the lipid energy model and summarizing the evidence that suggests this is the case, although we want to make a more specific study about it, hopefully this year or the next one, was published shortly after. Now, this phenotype of to be an LMHR, one of the, you could say, criterion, informal criterion, but reasonable, is to be sure you have normal lipids before restricting carbohydrates. So people who always had high LDL, regardless of your diet, they have something else, right? They are not LMHRs, they have something else that and that should be studied. Those who have normal lipids change their diet, and now they have this pattern of high LDL, high HDL, low triglycerides. Those are LMHRs. And Dave did something I think it's truly admirable. He crowdfunded a very expensive study because today the state of the art, the gold standard to measure atherosclerosis is coronary calcium angiotomography. It's a very expensive scan because, and there's also a wide range of prices. And one of the most advanced and expensive scans comes from a company named Clearly. Each scan is super expensive. It's multiple. It's more than $2,000. And basically, the idea of Dave was let's crowdfund a group of, confirmed LMHRs. Let's scan them at baseline, and then let time pass and scan them again to see if their plaque progresses rapidly. Now, let me be clear: these scans detect plaque in anyone. It's like I don't know if you've heard this about cancer, but like all of us get cancer multiple times a day, but our immune system fights it back. All of us have at least some form, or most of us will have at least some form of plaque. These scans would detect millimeters of different plaque. And the first study that was released, that was published in JACC Advances, compared the LMHR population with another population not restricting carbohydrates from the Miami Heart cohort. And here, everybody had its match. So, for example, if they have 55-year-old LMHR who smoked for 10 years, who had hypertension, and they found a Miami Heart 55-year-old man with hypertension who smoked for 10 years, and they would find the closest match for everybody. And after doing that, they got groups that were very similar in every classical cardiovascular risk factor except LDL. The LMHR population had twice as much LDL than the Miami Heart. And then they compared if plaque was different in LMHRs. And this is people who had been on LMA on a low carb diet for on average 5 years, who demonstrated they had normal lipids before their diet, and they had no more plaque than the Miami Heart patients. In other words, the LMHR is not explaining, LDL, high LDL is not explaining, it's not contributing to having more plaque. We have now in peer review the longitudinal data, because this was at baseline. We have now in peer review the longitudinal data. Hopefully we can share those results soon, but they are encouraging. They are encouraging. And we need more studies like this. When I said earlier that we need more research, we need more studies like these that have super advanced metrics and at the same time have corroborated LMHRs to see if plaque is progressing or not. Because let me be clear, atherosclerosis plaque can progress for multiple reasons. And it's simply a question of what's contributing the most to plaque progression. So that's what that study is about. And yeah, hopefully we can share those results soon.
We still have 7 minutes and Nina is already here. So can you give us a sneak peek of the cholesterol code movie? Dave Feldman was supposed to come in this conference, but then he sent a message that he's stuck up with so much work because this is coinciding with his COSI conference also, which was there last week. So he had to drop out. So can you give us, you have seen that movie, can you give a sneak peek? What what does it contain?
Sure. It has pretty much the story of how Dave came up with the LMHR concept, which is a very nice story because basically Dave has taken lots of pictures and taken lots of I don't think I know a human who has had the more lipid measurements in their life and started tracking his lipids with what he was eating. And the story of how the study was crowdfunded. It has also a summary of how the lipid energy model works, how is the LMHR triad constitute. But what I would highlight the most from the film, which I think it's especially valuable, because what I've mentioned before has been mentioned other times, is what I would highlight is that it has the story of patients who found they had this phenotype, who were struggling with different diseases. Some of them were struggling with inflammatory bowel disease, some of them with a psychiatric illness, some of them with type 1 diabetes, some of them, and how they found that they didn't have very high LDL, but now they did, and how they are now dealing with that finding, how their doctors were startled on what they were seeing and what decisions or resolutions they have made in response to this change. Because of course, many doctors would say, "Oh, you should leave the diet," like let's not worry about your LDL. But some others would say, I mean, this diet changed my life. I don't want to give. I don't want to. I don't want to stop following it. And I think that it's, I mean, don't take my word, it's biased. It's a very high quality production. Animations are amazing for explaining the physiological concepts. Dave's story is fantastic, but what I would highlight from the film is the multiple examples all across the board. There's children, there's elders, there's women, there's men. There's I would highlight the patient stories.
So coming to the final questions, um, how would you rate the risk factor posed by insulin resistance and blood sugar versus LDL? Because we have seen a lot of studies which compares, and I think in India we tend to ignore insulin resistance and blood sugar level, and the entire focus is only on LDL and total cholesterol. So, what would be your advice to the Indian public or population on this insulin resistance and blood sugar as a risk for cardiovascular disease?
What I would say is that this has been studied multiple times. Perhaps a useful reference here is a paper in JAMA published in 2022 from Dugani and colleagues, where they put head to head what shifts your risk meter the most. And having diabetes is by far, it's at least 2 or 3 times the effect of one large deviation of LDL, one full standard deviation of LDL. And the entire LDL risk was explained in this data set with small, dense particles. So I would go back to what we were mentioning minutes ago. What happens is that when we see high LDL in the population, that's typically signaling insulin resistance. So that's just the most common cause for high LDL. We know that you can put diabetes into remission or you control glucose with your diet. We know that high LDL doesn't mean the same in all contexts. And we also know that people have different benefits from their diet. So I think that talk to your doctor and analyze yourself. It's useful, for example, to keep a diary on how people were feeling and how their symptoms were changing. And it will be different for everybody. Talk to your doctor. And what I would say is that if I had to choose, yes, I'd prefer, well, I do. I'm open about it. I prefer to live with high ApoB than with high HOMA AR. So that's what I do, but I totally understand and see how different people with different contexts would receive different advice.
Dr. Adrian, thank you. And I think most of the questions I asked, you explained this in a very, very simple manner. And I think this is definitely going to benefit India. And I'll request Anup Singh to be brought on stage.
Thank you for the invitation.
Hello, Dr. Adrian. Thank you for coming.
Fine.
And before we wind this session off, one quick question. Why are doctors not looking at insulin? Is it because there is no drug, or is it ignorance?
I think there's multiple reasons. There's multiple answers. I would say that we do have a drug. We do have drugs that we know improve insulin sensitivity. However, the most effective intervention for improving insulin sensitivity is not a drug. It's a diet change. And doctors are not trained advising people on diet changes. So we should change the program in medical schools so doctors are educated with the tools to make impact on the most relevant contributor to insulin resistance. So part of that question is doctors are not trained to advise on dietary changes, which is the most important intervention for insulin sensitivity, but also very frequently in many parts of the world, doctors just don't have time. Even if we have a highly motivated, educated doctor who is aware of the power of dietary interventions and lifestyle interventions, sometimes they have 15 minutes per patient because they have to see 25 patients every afternoon. And one of the reasons why it's neglected is because doctors take 10 seconds in writing a prescription, but it takes a lot of time to explain someone how to read labels, how to prepare foods, which foods to avoid. So it's also a matter of how trained the doctors are, which is why I treasure this figure of health coach. Not some doctors don't like it, but I think that a health coach is a fantastic player in a healthcare system because they do have that time. So if and it's way faster to get more health coaches than clinicians. And health coaches are super motivated, and they very frequently are patients with successful stories who can give, practical life advice. So I think that part of the reason is doctors are just not trained to think like that. But sometimes, even when they do, because they self-educated, they don't have the time that it's required to actually educate someone and advise them on how to change their lifestyle, at least in many public systems. If a private sector is different, but most people in the world receive their healthcare from a public system.
And I would add one reason to that. Some have very big ego to change.
Oh, for sure. Absolutely. I mean, it's a bad idea to vest your ego on what you know or what you do. And I think nobody feels especially comfortable with the idea that I went to school for so many years and I've been practicing for so many years, but I have to recognize I still don't know how to fix a problem. That requires, some a good level of letting go your ego.
Thank you.
Thank you, Dr. Adrian. Thank you very much for explaining everything in a very, very simple manner so we can understand. We will love to have you again in one of our conferences, and I'd like to meet you once again physically. Thank you very much.
I would love to be there. Thank you for the invitation, and very happy to be here. Thanks for what you're doing.